Good morning, everyone. Lovely to see you this morning. I realize that people are going to continue to file in, but we're just going to plow ahead and get started. It's a great pleasure today to be able to welcome Ismene Petrakis from Yale. I had the wonderful opportunity and great fortune of working with her very closely in research leadership at Yale for several years in the Department of Psychiatry. She is a phenomenal institutional leader, wonderful educator and scientist, and was really delighted that she agreed to fly all the way out here and battle the time zone change in order to talk with us today about comorbidity with substance abuse and psychiatric illness. And in particular, you can see today's talk is going to focus on alcohol use disorders and PTSD. I'll give you a little bit of background. Ismene did her undergraduate degree at Northwestern and then was at Pittsburgh for medical school. She went to Yale. I don't know how long you planned on being at Yale, but I planned on being there for 4 years and ended up being 2 decades. And Ismene, landed at Yale for residency, and despite our best efforts, has remained there. So she was a resident and then did a fellowship at Yale in addiction psychiatry. She has been a continuously funded, extramurally funded researcher with a particular interest in treatments for comorbidities of substance abuse and psychiatric illness. She runs the extremely well-regarded T32. She leads the VA at Yale. And has, as I said, been a highly productive clinical researcher, more than 130 publications, numerous awards, and extensive service, particularly to NIH and substance abuse and psychiatric illness. So Ismene told me that she was going to bring a lot of focus today on the clinical side of the equation, and I told her that that was a wonderful idea. I think the DVLS ranges from very basic science, but hopefully increasingly will bring that science to bear on the problems that we face in the clinic. I think Ismene will give us a wonderful demonstration of that today. So thank you so much for coming. Should I tell them? She has a bit of a cold, so away we go. Thank you, Ismene.
Thank you. I got to put this down a little bit here. Thank you very much. It's a real honor to be here. I love San Francisco. I have lots of ties here, and I love this department. I have lots of friends and colleagues and ex-Yaleys and ex-trainees, and so it's really fun for me to be here. And as for the time change, at least this is at 8 in the morning because I've been up. I won't tell you what time I woke up this morning, but if it were later, I would be delirious. So. Okay, I'm going to be talking about multiple morbidities, alcohol, and co-occurring PTSD. And just in terms of disclosure, I've provided consultation to Alkermes, and the studies I'm going to present have been funded by the VA, Department of Defense, NARSAD, and NIAAA, and I will be discussing off-label uses of medications. So I thought we would start just talking about alcohol consumption. So alcohol consumption has been around for many, many years. The earliest drinks, the earliest kind of beverages date back thousands of years, and they were made from things like fruits or honey, dates, cereals, and it was also a big part of the culture as well. In the Sumerian and Egyptian texts, there was mention of medicinal wine. As you can tell from my name, I'm Greek, and of course the ancient Greeks had a god of wine. And after the 12th century, there were some mentions before the 12th century of distillation of alcohol, but it really became more prominent after the 12th century, where alcohol was distilled, and that increases the alcohol content. Now, alcohol is important in our own history. Since its founding, alcohol played an important role because early on it was safer to drink than water. So as Benjamin Franklin said, in wine there is wisdom, in beer there is freedom, in water there is bacteria. And currently, today, of course, there's lots of alcohol use. This is from David Sedaris. We were not a hugging people. In terms of emotional comfort, it was our belief that no amount of physical contact could match the healing powers of a well-made cocktail. So how many people do drink? It's estimated that 86% or so of adults in the U.S. have sampled alcohol in their lifetime, so a majority. 70% have used alcohol in the past year, and only 50% or so have used alcohol in the past month. But what we really want to focus on today is not just alcohol consumption, but when alcohol consumption becomes problematic. And what we talk about is DSM-5 calls alcohol use disorders, and there is this list of symptoms that you need to have. And if you have two or three, that's mild, and that's equivalent to what used to be alcohol abuse. Moderate is 4 to 6, and severe is 4 to 5. I can't even read. And severe is greater than 6. And the content is really about risky drinking, impaired control, social consequences, and then, of course, the physiologic problems of tolerance and withdrawal. But I have to say, if you wanted just a lay definition of alcoholism, I found this in Wikipedia, but then, of course, Wikipedia, they change it all the time, so it's expired. You won't find it there now, but I really liked it. I thought it was a great lay definition of alcoholism. In common and historic usage, alcoholism refers to any condition that results in the continued consumption of alcoholic beverages despite the health problems and negative social consequences it causes. So that really is it. It distilled down without checklists, and I think that is a great definition. Now, I want to just say a word about the neurobiology. Alcohol, like all good drugs of abuse, causes the release of dopamine between the ventral tegmental area and the nucleus accumbens. But unlike stimulants that have this effect directly, alcohol has most of it effects indirectly through other neurotransmitter systems, notably glutamate, GABA, and the opioid system. And the reason that's important is that many of the medications that we use to treat alcohol use disorders do affect those systems rather than dopamine directly. There's also increasing understanding that alcoholism is a stress disorder as well. So stress can lead to drinking in laboratory models of drinking. It's thought to be related to the initiation and maintenance of alcohol use disorders. It's involved in alcohol reinstatement in alcohol models. And then in humans, in laboratory models, stress can lead to craving for alcohol and is associated with relapse. And here I just have the, the cascade from the hypothalamus to the pituitary to the adrenal gland. You can see that's the stress response is mediated by that and leads to a number of neurotransmitters that are released, including norepinephrine, serotonin, and dopamine. And there's some evidence that alcohol, although low doses of alcohol might dampen the stress response, chronic alcohol consumption leads to dysregulation of the stress response, and it's mediated in things such as like alcohol withdrawal, where you see definite dysregulation. Now, I'm going to turn for a minute and just talk about PTSD. Well, what is PTSD? It's a disorder that occurs after someone goes through a traumatic event. And while a lot of people have a stress response, may have response to a traumatic event, this is what happens if the symptoms either persist or it interferes with an individual's function. And this is just to give you the reminder of the DSM-5 diagnosis. You have to have exposure to an actual or perceived threatened violence, death, serious injury, sexual violence. And then there are these clusters of symptoms, the intrusive symptoms, persistence and avoidance of reminders, negative alterations, and arousal and reactivity symptoms. And this has to, of course, occur for longer than 30 days. Now, a little bit about the epidemiology. It's been estimated that 70% of adults in the U.S. have been exposed to a traumatic event, but of those, only about 20% will develop PTSD, and at any given time, it's estimated that about 8% of the adult population in the U.S. has post-traumatic stress disorder. Now, these rates, the rates of being exposed to an event and then developing PTSD are much higher among women, where 20% of women are thought to develop PTSD after exposure to a traumatic event. So this is really important, and there are other subgroups, actually, let me come back to that. There are other subgroups that are particularly at risk for PTSD, and they include military veterans. And, as Matt mentioned, I work at the VA in West Haven. Those of you who work at the VA know that some of these facts, but if you don't, there are 25 million veterans living in the U.S. That represents 22% of men and only 1% of women. And just to give you some idea of what eras they served in, I broke it down by that, and there are about 7 million of individuals enrolled at the VA. So the reason I mention this is that the VA is, of course, very interested in the treatment of PTSD and in doing research in PTSD, because a lot of PTSD ends up going to the VA, and they've become leaders in this field. But one of the issues that occurs is that the VA primarily treats men, although we have a growing female population as well. And so a lot of the research that's been done, especially including veterans, is in men. And so this is important if you're thinking about translating research into a clinical practice. If you're in a practice that's civilian practice, you may have a lot of women that have PTSD, but some of the research has been done in men. And it's just something to keep in mind as we go through some of the work that's been done. Again, the neurobiology focuses a lot on the stress response, and this is another schematic of the hypothalamic pituitary adrenal axis that leads to the release of cortisol. Cortisol then provides a negative feedback to dampen the stress response, and this is thought to be hijacked in PTSD and can lead to some of the abnormalities that you see. And what happens then is it's really a disorder of noradrenergic hyperactivity. There's dysregulation of noradrenaline, and there have been elevated norepinephrine metabolites in urine, blood, and CSF, and increases in noradrenaline release with reminders to the exposure. So this is another schematic of this. I got this from my colleague and our chairman, John Crystal, and when I saw it, I didn't realize that it actually moves, but he's much better at making slides than I am, so I will just show it to you. Norepinephrine actually is moving out of the cell. There's feedback inhibition and transporter. These things are attenuated in PTSD, and you get dysregulation and overstimulation of noradrenergic receptors in PTSD. And then when you think about treating it, here's another one of his, the way to treat it, and a lot of the research that's been done is looking at treating the overstimulation by blocking some of the receptors. So for example, the alpha-2 receptors using guanfacine and clonidine. Now the alpha-2 receptors, as a reminder, provide negative feedback for the release of norepinephrine, so these are actually alpha-2 agonists. And then the use of alpha-2 antagonists, such as Prazosin, which we'll talk a little bit about. And then, of course, things that block beta receptors, including propranolol, and that's thought to be one of the mechanisms of some of the antidepressants that downregulate beta receptors. Okay. So, when I started, I said we were going to be talking about multiple morbidities. And so why did I use this term? It's something that we've become interested in thinking about. It's a concept that's used in medicine, like particularly in geriatrics. And the definition is having the prevalence of having two chronic conditions that interfere with either functioning or life and require complex health care management. It's estimated that 1 in 4 Americans has 2 or more chronic conditions. And this is sort of a different way of thinking of things than what we usually do in all of medicine, right, where we think about a single disease framework. This is how we do education. This is how we do reimbursement. This is how we do research. We think of one disorder and we see what we can do to address it. But in fact, you have to empirically test treatment for multimorbidities. And this is, of course, we also refer to it in psychiatry as comorbidity or dual diagnosis. And, of course, comorbidity between PTSD and alcohol is an important issue. You can see here this is some old epidemiologic data where individuals who have alcohol abuse and dependence have a 2 times chance of getting PTSD than the general population. And this is from the NESARC data, where the odds ratio is 1.4 that individuals with alcohol use disorders will have PTSD. And it's higher than what it is for major depressive disorder, the same as what you see for anxiety disorders. It's a little higher if you put all the mood disorders together. But again, you have a higher risk of developing PTSD. Now, it's even more dramatic if you look at it from the other way. If you look at individuals who have psychiatric disorders and develop substance use problems. And on the left, you can see that this is the general population, the rates of alcohol use disorders and illicit drug abuse. And then in the middle in the box, you can see in PTSD, you have it's 3 times as likely if you have PTSD to have an alcohol use disorder than the general population. Okay. A few harmless flakes working together can unleash an avalanche of destruction. Now, I don't mean to imply that having PTSD alone or alcohol alone is harmless, but the point I'm trying to make is that the two combined together can cause a lot of problems that are not explained by just additive. They really can unleash a lot of problems. And so what kinds of problems? Well, the course of each disorder clearly has been documented that it's complicated by the presence of another disorder. So the symptoms of PTSD are worse in those who have comorbid alcohol use disorders, and there are higher rates of relapse to alcohol among those who have PTSD. There are also other problems like higher rates of suicide. Now, this is not, of course, completed suicide. This is suicidal ideation, but 66% of individuals reporting suicidal ideation, which is pretty high. So these consequences can be quite devastating. And there have been several mechanisms to talk about what underlies this comorbidity. I'm sure everybody's heard of the self-medication hypothesis that suggests that individuals use substances to manage their symptoms, but there are other hypotheses as well. The high-risk hypothesis, that individuals who are engage in high-risky behaviors lead to situations where they may develop PTSD, and they also develop substance use disorders. There's a susceptibility hypothesis that poor coping leads to the more likelihood of developing PTSD, and then the common factors hypothesis that common precursors lead to trauma and substance use disorders. And this is from a review of the neurobiology of PTSD and alcohol use disorders. I think there's new, emerging interest in really studying this, and you can see the differences in the sympathetic nervous system output and the HPA axis in both PTSD and alcohol use disorders on the left and on the right. But there aren't a lot of good studies looking at things like basal cortisol level in people who have comorbidity. So I think this is still an emerging young field. And the corollary to that is then do treatments, things like, for example, that affect the noradrenergic system, are they capable of addressing both disorders? And this is still, I think, an unknown question. But we'll talk about that in a minute, too. So I have another quote here. This is by Louis B. Puller, who was a Vietnam veteran. I don't know if you all know his book. He wrote this book called Fortunate Son. He was seriously injured in Vietnam and came back and suffered from alcohol use disorder, PTSD, depression. He wrote this autobiography after he had recovered. He ran for elected office. He became a lawyer. Unfortunately, he ended up, after the book was published a few years later, he ended up committing suicide, but this is just one quote from it. It's a really interesting book. I felt used up and discarded, and as I tried to dispel with alcohol the magnitude of the obscene fraud of which I had been a willing victim, I was assailed by conflicting and unresolved emotions. Now, I have to say that the book also had some political overlay because it was after the Vietnam War and he was opposed to it, but nevertheless, it's a pretty interesting read. So when you use the single disease framework, what are the problems with that? Well, first and foremost, especially in PTSD and alcohol, what you get is compartmentalized treatment settings. We're much better at that than we used to be, but even in this day and age at RVA, we have a separate PTSD program and we have a separate it's a substance use disorders program. And while our staff are becoming more and more trained to treat both disorders, we still get compartmentalized treatment. And the problem with that is that you get maybe misdiagnosis. Either patients don't report the symptoms or clinicians don't recognize them, and then there are problems with engagement. You're offering a treatment the patient perhaps does not want. I think we're better than the days where the sequential treatment was the norm, where people would be told, go treat your alcohol use disorder and then come back and we'll deal with your PTSD. I don't think we do that like we used to, although maybe not. Hasn't been eradicated completely. Nevertheless, I think it's important to understand how to treat these when they co-occur. So I'm going to talk a little bit about some of the treatment literature that's out there in treating these disorders. And there have been several groups, including ours, including some of you here, Steve Bakke, asking questions about what strategies, for example, for pharmacologic management, what strategies make sense? And the one question would be, are the medications that are out there to treat alcohol use disorders effective in treating alcohol use disorders when there's comorbidity? Another strategy is, what about the medications that are used to treat PTSD? Are they effective in comorbidity? And then the third strategy is maybe to target some of the underlying neurobiology and see, is that an effective strategy? So these are the medications used to treat alcohol use disorders, and I put them in a timeline of when they were approved by the FDA, mostly to show you that there was a big pause, if you want to call it that, from 1951 to 1994, where there really were no medications to treat alcohol use disorder except disulfiram, which, as you know, is not that popular. And so when Naltrexone was approved, those of us who are old enough to remember it, it was very exciting. There was a new medication to treat alcohol use disorder. So early in my career, we did a study, and this is with Bob Rosenheck, where we wanted to ask what is the utilization of naltrexone in the VA nationally. And one of the fun things about the VA is that you can actually do things with a very large data set. So in this case, we had 194,000, can't see, individuals who had alcohol use disorder nationally. And so we ran all the people who found the diagnosis and then asked the question, what percent are prescribed naltrexone? And we found a very low percent that were prescribed naltrexone. It was less than 2%. And just as an aside, subsequent studies have shown that the percent hasn't increased that much, despite lots of efforts by the VA to try to increase the prescribing of medications to treat substance use disorders. But one of the interesting things that we did find, besides the low percent, was that people who had comorbid disorders like PTSD, depression, people who had been in a psychiatric hospitalization were more likely to be prescribed naltrexone than individuals who didn't have these comorbid disorders. And we thought this was very interesting because these disorders, all the studies that had been done in naltrexone systematically excluded comorbidity. So here the studies are being done in a different group, and yet it's being used in a group of individuals who have comorbid disorders. So we started a study that, this was under the mentorship of Bruce Rounsaville, who's since passed away. And this was a multi-site study that we did to look at the medications at the time that were available, naltrexone and disulfiram, to see about their efficacy in individuals who had any comorbid axis 1 disorder. So this was not just PTSD. It was a sort of a messy study over 3 VA sites in New England. And after we did the main study, we noted that a large percentage of our patients had post-traumatic stress disorder because it was a VA. It was one of the largest. I think depression was the first diagnosis of the most people, and the second was PTSD. So we did a secondary analysis to see whether does the diagnosis of PTSD influence outcome in any way. And lo and behold, we found that it did. So the blue bars are the individuals who have PTSD, and this is consecutive days of abstinence. And so higher is better. And you can see that those individuals who get any medication, either naltrexone, disulfiram, or the combination, did better than the individuals on placebo, whereas in the white bar are all the people who also have axis 1 disorders but don't have PTSD, and there's really no difference there. So our patients with PTSD did better on medications than our patients who didn't have PTSD. Now, we aren't the only group that was interested in naltrexone and comorbidity. Edna Foa and her group did a study, and they did something very interesting because they combined naltrexone with prolonged exposure, which is one of the psychotherapies used to treat PTSD. And they had 4 groups: prolonged exposure, a supportive therapy, naltrexone, or placebo. And what they found is that individuals in their follow-up at 6 months, the group that did the best, there was some overall effect of naltrexone and follow-up, but the group that did the best were those that got prolonged exposure and naltrexone. And then we did also a second study. We became more interested in PTSD alone and started a study, which I'll tell you about in a minute, where we actually recruited, unlike that first study where we did a secondary analysis in PTSD, this was a study where we actively recruited only people who had PTSD and alcohol. And we were interested in evaluating the antidepressants, but we also added naltrexone or placebo to see whether that augmentation would decrease alcohol use. And in this study, which I'll tell you about more in a minute, naltrexone, the augmentation of naltrexone decreased craving but didn't have any effect on drinking outcomes. So, 3 studies, what do you conclude? Well, I mean, one thing that you conclude, which is not insignificant, is that these medications can be used safely in individuals with PTSD. So I think that's important because they're being used in settings, at least like the VA. Second is that these can be effective in preventing relapse. But they're only effective in either stringent alcohol use outcomes, or in our study it was only craving but not alcohol, so they don't really have that much of an effect size, so probably there's room for improvement to find other avenues of treatment. So I mentioned another strategy is to look at the medications for PTSD, and the 2 that are FDA approved, of course, are sertraline and paroxetine, and there are, of course, guidelines that other medications may be effective, but those are the 2 that are FDA approved. And then there was some data, there were some studies, I think it was the early 90s, where the SSRIs became of interest to people who were alcohol researchers, because at least in animal studies, the SSRIs decreased alcohol consumption in laboratory animals. And there were these few little studies done in heavy drinkers, so they weren't alcohol dependent, and there was some effect of the SSRIs in decreasing alcohol use. So there became this sort of interest in the use of SSRIs, maybe in alcohol use alone, but also in comorbidity. And the first person to do this work was Kathleen Brady. She had done an open-label study with sertraline and found that it decreased both drinking and PTSD symptoms in a very small sample. So she did this randomized trial. Now, in this trial, 34% of the individuals were women, and this becomes important later when you think about all the data. And what she found overall is that sertraline was not effective either in treating PTSD or in attenuating alcohol use in the sample overall. But she also did this cluster analysis, which was interesting. So she clustered people whether they had severe alcohol use disorders, which was defined as an early onset of alcohol use disorder, and whether they had early or late onset of PTSD. So cluster 3 are the individuals who have the more severe form of alcohol use disorder and earlier onset of PTSD. And what you find is that in that group, the sertraline actually made their drinking worse. And in the other groups, there may have been an effect of the sertraline. So this is actually consistent with data that's been done since then, looking at the SSRIs in alcohol use disorders, in which individuals who have early onset of alcohol use disorders actually do worse with SSRIs than individuals who have late onset. And then this is our study that I mentioned before. We, too, were interested in the SSRIs as possibly a treatment for PTSD and alcohol based on that other data and based on Kathleen Brady's early study. But we wanted to do an active comparator, so we compared it to the use of dizipramine, which is a noradrenergic antidepressant. So in our study, we did not have a placebo control for the antidepressant. And then we added naltrexone or placebo, so we ended up with 4 groups as well. And we had some interesting findings. Our PTSD symptoms, they got better between both groups, and there was no difference. So the SSRI and the dizipramine improved PTSD symptoms. But again, we didn't have a placebo, so we're not sure whether that was an effect of time or whether both medications are effective. What was interesting, though, in terms of our alcohol use outcomes, is the individuals that were treated with dizipramine had better alcohol use outcomes than those treated with actually paroxetine. Have I been saying sertraline? We did paroxetine, not sertraline in our study. And the addition of naltrexone, as I mentioned before, did not change alcohol drinking at all, but it did improve craving, whatever that's worth. And then the final study that was done with this is a more recent one done by Denise Hine, where she took, this is a sample of, I think, either primarily or entirely women, civilian, not veterans. Oh, I should mention that in our study, of course, it was 98% male, I think, 98, 97, something like that. So in this study, she did this primarily in female subjects, and she had everybody did a psychotherapy called Seeking Safety, which is a cognitive behavioral therapy that was designed specifically to treat comorbidity. And then she randomized people to sertraline or placebo, and in her study, there was an effect of sertraline. This is a change in CAP score, so again, higher is better, and you can see that the sertraline-treated individuals did better than the individuals who got placebo. So there's some evidence, especially in the Hines study, and maybe in ours, although ours is hard to interpret, that SSRIs help PTSD in comorbid group. And maybe there are even gender differences, as there have been found in other settings. However, really consistently, the SSRIs were not effective in decreasing alcohol consumption in any of those studies. And in fact, the SSRIs are worse for those with more severe alcohol use disorders than in those that have early onset. So the third sort of strategy has been to take medications that are thought to target the common underlying neurobiology. And the one I'm going to start with, of course, is Prazosin. So Prazosin is an alpha-1 antagonist. Its market name is Minipress, Vasoflex, Hypovase. I'm sure you've seen it prescribed. It's used for hypertension, but it's also been studied to look at especially treating the sleep disturbances in PTSD. And most of that work has been developed by Murray Raskin and his group up in Seattle. And he has done studies that have included men and women, civilians and veterans. And there's a large cooperative study that is now actually completed. I think the paper is being reviewed, but it hasn't been published as far as I know. This is from one of his studies where he did it in combat veterans. And in this study, you can see Prazosin's effect was mostly on treating some of the sleep disturbances. But in this study, it actually was effective in treating the PTSD symptoms overall based on the CAPS, which is a assessment of PTSD symptoms total. And you can see the Prazosin is in blue, and people get better on Prazosin compared to placebo. So before I talk more about it, I just want to mention this one study that I don't know if you've seen it, but I thought it was a great study that was done by two of my colleagues at Yale, Ilan Harpers-Rodham and Bob Rosenhack. And what they were interested in to see the diffusion, they called it, of knowledge. So where was Prazosin? What they did really is they used VA data again, and they looked to see where was Prazosin prescribed. And it turned out, so that's Seattle. We're way over on the right. You guys are underneath. I didn't star California. I'm sorry. But what they found was that if you're less than 500 miles from Seattle, the rates of prescribing Prazosin were very high. And as you go out further and further, the rates dropped. So they had a very nice way of describing it, that there was, they called it local diffusion, right? Isn't that what the name of the study is? But I thought it was very interesting. So if you're in the zone of influence from the Seattle group, you prescribe Prazosin. I think you guys are right outside. How many miles is it to Seattle? Like 800 or something? I don't know. Anyway. Further than 5, okay. Now, if any of you have ever heard Murray Raskin talk about his Prazosin data, it's very charismatic and very compelling, so I don't think it's completely surprising. Anyway, I thought that was very interesting, how knowledge gets disseminated or practice changes. Anyway, then Prazosin was also used, again, by Seattle Group to look at its effect in alcohol consumption, not in comorbidity. And this was done by Tracy Simpson. It was a 6-week study, and they found pretty robust effects of Prazosin on drinking in a non-comorbid group. So we became interested in it, and we did a study using Prazosin to treat comorbidity. And this study was published, I think, last year sometime. And this was 2 sites, VA sites, mostly men. Again, it was 90-something% male. And we randomized people to Prazosin or placebo who had comorbidity, and they were allowed to take other medications for their PTSD. And we found, this is our drinking, right? I can't see it on here, yeah. So in terms of drinking, everybody got better. You can see drinking goes down over time, but we had no effect of Prazosin on our drinking outcomes. Now, it was 2 sites. One was Bedford, Massachusetts, and one was West Haven. We did have some site differences. You can see that the Bedford people drink less than the people in West Haven. Our only explanation for this was that, and actually even in our site, there were a high percentage of patients who were in sober housing, and in Bedford they have a domiciliary with more sober housing than we had available, so we attributed that to the sober housing. But anyway, or I don't know, there's something about West Haven, I'm not sure. And then this is our PTSD symptoms based on the CAPS. And you can see that, in fact, there is really, I mean, there's this one time point, but there's no difference between Prazosin and placebo in our PTSD symptoms. And most disappointingly is that even if you just look at sleep, because not all of the other Prazosin studies showed changes in PTSD symptoms, but even if you look at sleep, we found no differences between Prazosin and placebo. Now, of course, we're not the only group that thought of this idea of using Prazosin for comorbidity, and this is Tracy Simpson also did a study. She had done the study in alcohol alone, but she also did a study in comorbidity, and hers was mixed veterans and non-veterans, so she had a higher female sample than we did, and she found no effect on PTSD symptoms, but she did find this nice effect on alcohol consumption, looking at heavy drinking days and drinking days, right? Yeah. So, Prazosin doesn't seem to be that effective in treating PTSD symptoms or even sleep in this comorbid sample, but it has some mixed effects on alcohol consumption. So I don't think the story is completely done yet, and maybe there are other factors that overwhelm any medication effects, such as sober housing. Now, the other studies that have been done, and they were done here at UCSF, is to look at the anticonvulsants for treating PTSD and alcohol use disorders. And I'll say in a minute about alcohol and topiramate, but I think one of the reasons that makes them a compelling choice for comorbidity is there's data in alcohol use alone and there's data in PTSD alone. The data in PTSD is smaller. There are, I think, 4 studies, and they've been used both as monotherapy and adjunctive therapy to treat PTSD, and there's some sense that they may be effective. But most of the data that's really compelling is in alcohol use disorders, and this is from a meta-analysis published in 2014 of all the studies that looked at topiramate to treat alcohol use disorders. And there is a clear effect on abstinence, heavy drinking, craving, and biological markers of drinking. And I think topiramate, at least at our site, is being used not as a first line, probably Naltrexone is a first line drug, but it's actually being used pretty frequently for alcohol use disorders, even though it's not FDA approved. Anyway, Steve Bakke did a nice study looking at topiramate for alcohol use disorders in veterans who also had comorbid PTSD. This was a randomized trial, and he had some nice effects here of drinking, mean and median % drinking days per week, and you can see topiramates in red and placebos in blue. But one of the problems, of course, with topiramate is its side effect profile, because it causes some of the cognitive side effects. And Steve did a really nice part of the study where he added measures of cognitive function to see exactly what does happen with topiramate over treatment. This is important, especially with people who have alcohol use disorders. And you can see that the topiramate did have an effect on learning and memory. But the good news, I guess, is that people did recover as you get closer to week 12. So we've been interested in, there are lots of different ways to go next. I'll tell you what we're interested in. At some point, I'd be interested in talking to Steve to see what he's doing. And this is sort of what some other groups are doing. But I think the story with the noradrenergic medications is still alive and kicking, even though we did have our negative studies with PTSD, but there's at least some evidence for alcohol use disorders, perhaps using them in combination or different agents. The anticonvulsants, I'll mention our work in zonisamide, and then some novel work. At least one of my junior faculty members is interested in neurosteroids. So this isn't as fancy as the other. The balls don't move, but here are the different noradrenergic receptors, alpha 1, 2, and beta. And one of the possible strategies. Well, one is to just use a different alpha-1 agent like Prazosin, which is being tried by several groups because it's longer acting, and I think the theory is that maybe the Prazosin effect was too weak. But another would be to combine medications and to affect more than one receptor. I don't think that's being done clinically, but there is some preclinical data that suggests that combination is better than either alone. And this is just from Dennis Rasmussen and his group, where this is an animal model, and they gave individuals propranolol, Prazosin, and the combination, and found that the combination was more effective in terms of decreasing drinking than either medication alone. So that's one strategy. Another avenue is the anticonvulsants. We've become interested in zonisamide, which has a pharmacologic profile similar to that topiramate, but we're hoping has fewer side effects. I have a colleague at Yale, Al Arias, who was involved with one of the 3 small clinical trials that was done in alcohol use without comorbidity. And this is from his data, where heavy drinking days, individuals treated with zonisamide did better than those on placebo. So we got a small grant from what was the Gallo Center at the time and the Department of Defense. It was a collaboration, and did a small study with zonisamide that we're hoping to get more funding to finish because this only had 20-some subjects, where we combined zonisamide to a psychotherapy. I'll talk about that strategy in a minute, and found that this is just craving, but we had some findings with alcohol consumption as well, that zonisamide was better than placebo. So we're hoping to follow that up in a larger study. So the other area that one of my colleagues is interested in is in the neurosteroids. So these are endogenous neurosteroids that are thought to be involved in the stress response, and they are thought to mediate a lot of their effects through GABA, and they restore GABA and HPA systems and are responsible for homeostasis. There's evidence that chronic stress alters the neurosteroids, and so does alcohol, and so this may be a target for pharmacologic management. This is just one of those, has too many, I should have probably squared it, but the pathway that we're interested in is the progesterone going to allopregnanolone. This is work by Leslie Morrow, and you can see that that is an area where there may be some pharmacologic management that's possible. So this is important in PTSD, where there's lower allopregnanolone expression in animals, and there's some interest in looking at allopregnanolone synthetic analogs as treatment for PTSD. There's a drug company that is doing something to this. I'm not sure what the results of that are, but this may also account for gender differences in PTSD, and this is the hypothesis of how it might be what the mechanism might be in alcohol use consumption. And you can see that it's been postulated that neuroactive steroids might be therapeutic during withdrawal or possibly for preventing relapse. And we recently were funded by NARSAD to do a small study to look at that in the laboratory in individuals with comorbidity. It's really hard to give allopregnanolone. You have to give it IV, and it's not very stable, so we're going to use progesterone as a precursor. So. Okay. So you can do anything you set your mind to when you have the vision, determination, and an endless supply of labor. So this is what it feels like for those of you who've done comorbidity studies. It feels like you're building a pyramid. It takes a really long time. I don't know if you noticed that from our studies. You can run these studies for many years, so there's got to be a better way to test some of these medications. So we've become interested in possibly using, laboratory paradigms to test medications that will take a shorter time. So this is my colleague, Elizabeth Rulevsky. This is kind of staged because the patient is not really a patient. He's another one of my colleagues, Lou Trevison. But anyway, so the way these stress paradigms work is that you interview individuals for either a stressful event, and we've then taken that to work in PTSD as well. But you interview them about a stressful event, then you record it, and then you bring them back into the laboratory. They listen to it on the headphones. Imagine that you're, whatever it was, a fight with your wife. Imagine that you're talking to her, and you have a lot of detail. And then you measure things like, you can measure cortisol, you can measure heart rate reactivity, but you can also measure craving for alcohol. And this is work that people a lot of groups have done this, but at Yale, Rajita Sinha has been doing this. with substance use alone. And you can find that you can use it as a paradigm to test medications that might dampen the stress response. You can evaluate its effect, how it relates to relapse after they leave the laboratory. So we became interested in doing that, but taking that to the comorbid group. So we have done some work where we have not only done stress reactivity, but reactivity to traumatic events. So you talk to them about whatever their index trauma is that led to their PTSD. You bring them into the lab. And Elizabeth Rulevsky has some interesting data that was, I think it's under review, the paper's under review. So she brought these individuals in and they had these three conditions: a neutral condition, a stressful condition, and a traumatic condition. And you can see that both stress and trauma reliably increase craving and desire for alcohol compared to the neutral. I mean, that's not surprising. But what we did find is that there was a significant effect of trauma, where trauma produced these cues more reliably than did stress. It's not much of an effect, but nevertheless, this is a salient trigger for alcohol craving. And she found the same thing in terms of anxiety. Oh, no, actually, sorry. In anxiety, there was no difference between the stress and trauma. Both of them reliably produced this anxiety compared to the neutral, but the craving data was at least intriguing. And we were intrigued about what it meant, but also to use this as a paradigm where you might be able to test medications before you launch on a large clinical trial. You can test something in the laboratory to see whether it may dampen this response. And she also found, as it has been found before, that there was a relationship between stress reactivity and drinking at follow-up. So, okay, so we spent most of this time talking about medications. I just want to, for the last few minutes, switch gears. So when you only focus on medications, you're looking at a very small piece of a bigger picture, and so you may be missing sort of the whole thing if you only do medication. So there's a whole literature, too, which I don't have time to really go over, but about behavioral interventions to treat comorbid alcohol dependence and PTSD. And similar to the framework of the medications, I think investigators have asked the same question. So if you have a behavioral intervention to treat alcohol use disorders, is that effective in comorbidity? And then another strategy would be, what about the behavioral interventions used to treat PTSD? Can you do that in people who have comorbidity? And that's particularly important with interventions such as prolonged exposure, in which you are exposing an individual to trauma and then you're treating them, but is that going to cause relapse? And there has been a lot of reluctance to do that, but increasingly groups are looking at that. And then the third strategy is to develop a behavioral intervention targeting both, and the best example of that is seeking safety, which has been developed as a cognitive behavioral therapy for intervention, intervening with both. And that was developed originally for women who had been victims of sexual assault. So again, this is beyond the scope of this talk, so I gave you 3 articles if you're interested. And this is a little bit of an advertisement because we just published that first article, which has a nice review, I think, of all the behavioral literature. But there's also this nice meta-analysis and systematic review done by Roberts et al. That goes over that. And I'll give you a little bit of a spoiler alert. One of the things that seems to be true is that the behavioral treatments that focus on trauma-focused interventions seem to be very well tolerated in this group, and perhaps better in terms of treating comorbidity than other types of treatments. So I think that's an intriguing tidbit that needs to be followed up. So the behavioral treatments, there's some evidence that they have more lasting effects. Medications may only work while you're taking them. Behavioral treatments teach coping strategies, which may improve the quality of life and allow people to figure out how to address, to deal with issues as they come up. And they may work not as quickly as medications, so perhaps one of the best strategies would be to combine the two, use behavioral treatments that will have lasting effects, and then you can use medications for symptom relief. And in fact, this has been done by several groups, and we mentioned a few of them already. So Edna Foa did the study with prolonged exposure and naltrexone, and Denise Hine was looking at seeking safety with sertraline, and then we have become more interested in cognitive processing therapy. So the VA, being a leader in PTSD, has these evidence-based therapies that they recommend. One is prolonged exposure, but the other is cognitive processing therapy, which is based on principles of CBT, but does have a component of exposure to a traumatic event. It's 12 sessions. And we modified a version of it to add some alcohol education. This is 2 postdocs that worked with me who took the CPT training from the VA and tweaked it a little bit for comorbidity. And in this was a case report as she was developing, this is Alyssa McCarthy, as she was developing this different treatment. She had a patient who was doing very well in terms of his PTSD symptoms, but continued to drink. So at week, I forget what it was, 9, I think, yeah, at week 9, he came in and said, I just drank a lot. I really have to do something about it. So she worked with a physician, added disulfiram, and lo and behold, he not only stopped drinking, but his PTSD symptoms continued to improve. They didn't get any worse, which is one of the things you worry about. So we wrote this up as a case report, but became interested in using CPT with pharmacotherapy. So that pilot study I told you about where we used zonisamide, we actually also used cognitive processing therapy. So all the patients received cognitive processing therapy, and then we randomized them to receive either zonisamide or placebo. And again, we didn't have an active control, but the PTSD symptoms improved over time, and then we had some effects of alcohol with craving and one of the alcohol use outcomes. Okay, so just to finish up, I think that you can't forget the kinds of patients that we're treating. I mean, we do these research studies, and giving naltrexone is important, or trying this medication, but of course these people come with lots of different problems, and this is just one case example of some of the kinds of patients we treat. This is a 27-year-old. This is a composite. It's not exactly one patient, but recent war veteran living with his wife and young child. He's experiencing symptoms of anger, isolation, depression, startle, but he's not in any kind of treatment until he's drinking, and he's drinking heavily with blackouts. He's not in any kind of treatment until when he's intoxicated, he assaults his wife, and the police are called, and all of a sudden it's a huge problem. He's in court. We're trying to have them come to treatment, and this is the kinds of individuals that we're trying to treat. And obviously, one medication is not going to solve all this man's problems, so I think it's important to think of more holistic care. All we ask that you give us your heart. This is what we ask of our staff, and I just want to acknowledge all the people that I've worked with, because these studies are very, very hard to do, and these are some of my mentors as well as some of the staff that have worked on these projects over the years. That's it. Oh, sorry, yeah.
Thank you so much for interesting rounds. I wondered, are these purely alcohol dependent? In other words, is there co-occurring marijuana use going on as well? And I'm just wondering what your take is on that in relation to this.
So, yeah. So this.
I want to make sure, because there are people behind it, if you repeat the question.
Oh, yeah, sure. She's asking whether there are other comorbidities besides just alcohol, other drug, right, marijuana. In my sample, right. So, yes. And I will tell you that when I started doing comorbidity work, we tried to do everything very purely. People would only be on one medication, and they couldn't have anything else, and then you get no subjects, and you have no study, and it falls apart. And so we have learned to adapt and be flexible, and it's always one of the problems. I mean, on one hand, if you have a sample that represents what's in the clinic, which is a messy sample, then your results are going to be more easily translated. On the other hand, sometimes it's hard to know what it is that's messing up with your research. So yes, they have. What we typically do is exclude cocaine dependence, but they sometimes use cocaine. They definitely have marijuana use, and that's just increasing with the medical marijuana as well as other legal. I mean, in Connecticut it's not legal yet, and it wasn't when we were doing the studies, but marijuana use is just everywhere. So yes, they have other comorbidities. Yeah.
I'm interested in in the use of psychedelics, and I know, obviously, years ago there was interest in LSD. I think there have been some meta-analysis that suggests that actually that original data might have been more positive than originally kind of suggested. And I'm wondering if you have a take on that.
Yeah, well, I think it's really interesting. There's several areas that are interesting and controversial. So the one is the psychedelics and the other is cannabis. I think that, it has to be tested. I don't know. In terms of the PTSD literature, the patients and others are more interested in cannabis than the psychedelics. I think the psychedelic literature is more aiming toward depression and end of life and those kinds of things. But I think it's an interesting questions that probably should be asked, but they're so fraught with political and other. There's a study that they're supposed to be doing with cannabis for PTSD, and I just read, I think in the New York Times, that Johns Hopkins was going to be a site, and they pulled it because the quality of the cannabis wasn't very good, or it's so complicated. I don't know. So this is my New York Times, not my scientific reading, but yeah. Dan.
Great talk. One of the things that I think I saw in some of your earliest slides, I don't know if you could go back to Petrakis 2006, but I think I saw it in the Brady study as well, which is, did you see any indication of a blunted placebo response in the PTSD group? It looked like in one of the slides that was driving the effect, and I thought it was interesting.
Blunted placebo. This is the Is this Brady?
Before that.
It's Brady? Can't see him.
I think it was clearest in...
This one?
Earlier.
This one?
Yes. So if I understood, this was looking at how the presence of PTSD modulated the response. And
right.
It looked to me like the responses were pretty comparable, except in the placebo group.
Right.
And I thought, well, that could just be a quirk of the sample. But then it looked, if I interpreted the Brady data correctly, it looked like there might be something similar going on where they just had higher rates of drinking in the placebo group when there was PTSD present. And I'm just wondering if that was something you even noticed or paid any attention to in the analysis. It strikes me that I wonder if PTSD makes the alcohol use harder to treat, even placebo-wise.
Yeah. Maybe. So this study. So the problem with this study is it was really pretty messy. So this study, the original was any axis 1 disorder. So we had people with schizophrenia and depression and PTSD, and then we did this secondary analysis. We also had randomized to naltrexone, disulfiram, the combination, or placebo. So there were 4 groups. And the disulfiram was an open randomization, like they knew they were taking it. So if some patients got 2 bottles, that meant they were on disulfiram, and some got 1. That means they were either on naltrexone or placebo. And then it was really hard to tease apart. The original hypothesis was that the combination would be the best, and naltrexone would help craving, and I don't even remember what we were thinking back then, but what we found was that we really saw only effects if you lumped all the medications. We did this analysis at the end that were, what do they call it, where we just did 2x2s even though there was 4. So it was any medication versus no medication. It was naltrexone versus disulfiram. It was combination versus either alone. That was the way we did the analysis, just to simplify, because we sort of not sure what we were looking at when we looked at the 4 groups. And what we found is that at least in the most stringent outcomes, which is consecutive days of abstinence, so we didn't see it for heavy drinking days, what we found is a little bit of an effect of medication, and it was more pronounced in the individuals who had PT. It was probably driven by the people who had PTSD. In fact, we actually had pretty good outcomes. These people actually did better. I don't have the rates of abstinence, but our abstinent rates were higher than you'd think.
Pretty high. But it does look like most of this effect is actually driven by the placebo data.
Yeah.
Thanks.
Yeah. Oh.
Oh, no. I only got one.
Let me take my remarks by saying that this type of clinical research study with randomized controlled trials and trying to get large enough N is extremely hard for the investigators and the results of it.
Yes. Yes. Thank you for saying that.
So my question has to do with maybe it's time to change some of our methodological paradigms. And I wonder on your thoughts on that. The reason is, here you selected to face the real world. There are these comorbidities, and they extend beyond the combination of PTSD symptoms and alcohol dependence to personality problems. And that's one reason PTSD got lifted out of the anxiety disorders, with the idea that there's an anxiety circuitry and we can target biochemical changes to the anxiety circuitry. It emerges from all this really hard research. It's not an anxiety circuitry disorder. It's a complex combination of things. So what I'm wondering is, maybe it's time to do longitudinal studies with individuals and see what changes for an individual when, and try and find out why in a complex array, rather than trying to take something like exposure therapy plus a drug, and then say, well, 12 weeks of exposure therapy is enough treatment for PTSD. I don't think it is. I don't mean it's not helpful in studies, but it simply is not enough length of treatment to recompose a person's relationships, identity, regulation of emotion. So what do you think about changing our basic paradigm?
Well, I totally agree that they have to be changed. I just don't know where to go with that. So we were actually thinking shorter rather than longer, because we were thinking of laboratory studies, which are, believe me, fraught with problems. But the thing that appeals about those is you can, run you can do it in 2 years. You can run a bunch of subjects, and you can see whether it changes, say, reactivity in the lab. What you don't know is, does that have any meaning in real life? I don't really know. You can follow them up for a little and see if they relapse. The other spectrum is to use big data like VA data, where you can get thousands and thousands of subjects, but that you can't get the only things you can get is whatever you find in the chart: diagnosis, number of hospitalizations. And you can do some of that longitudinal work with like health services data, and that's what Bob Rosenheck loves. He loves like 30,000 feet. You look at it, but you don't know things like personality structure from the chart. You just get diagnosis and number of hospital days and how far are they from the, are they rural or urban, and what, ethnicity or whatever's in the chart. So I don't really have the answer. If somebody has a great idea, I'd be willing to listen, because I agree, these 12-week studies, they don't move knowledge that much further. They a little bit, and I think they add some value, but they don't change the way you practice that much. Yeah, Steve?
Yeah. Ismene, great talk. Thanks so much. Just a couple of comments and a question. About the pyramid, you showed some of our work that showed less impairment in memory at the end of the study, but that is probably because the final week of the study we tapered off placebo, or it's a pyramid. So I think one has to assume that those real differences in Hamilton verbal learning scores that we showed persist throughout the pyramid treatment. By the way, we're now fairly far along in a much larger replication. That original study was an N of 30. We're now nudging up against 100, and
that's great.
Ultimately 150. This stuff, as Marty pointed out, it was extremely difficult. The treatment is hair-raising, hard, and just a terrible problem. The question I had was, in looking at all these various studies of alcohol and PTSD symptoms, whether they're psychosocial, pharmacologic, or both, do you have any impressions about the temporal relationships of resolution, improvement, changes in these symptoms in one domain or another? I'm only familiar with one study that's looked at that, and that's Denise Hines' work. Unfortunately, for those of us who are addiction researchers and would hope that addiction drives everything else, I think what she found was that traumatic symptom resolution appeared to then lead to alcohol use reduction.
Right. No, I have that same impression based on her work, and I think the people in South Carolina have something that shows that as well, that if you treat the PTSD, the substance use gets better, but if you only treat the substance use, the PTSD doesn't necessarily get better, which argues against that whole sequential thing that we did for so many years. But I think that's a great question, and we're going to look at our data, our Prazosin data, to see if we can get anything out of that, but I don't know whether that's true, but that's my impression as well. So. Yeah. Sorry, man.
No. What is the role for biomarkers in this field? Biomarkers for long-term alcohol use as well as adherence to disulfiram and naltrexone?
So if you mean biomarkers like are people drinking, I think there are a lot of people use those in research studies. So, you can use GGT or CDT, and now you can actually, look at ETG in the urine. And so a lot of people use them, and we use them in most of our studies, mostly as just a confirmation that what we get from self-report is true. But a lot of the data that people report on is still self-reported data because the biomarkers are either too short or they don't, at least with self-reported data, people tell you how much they drink, whether it's accurate or not, you're not sure. But even if you follow something that, like GGT, you can see changes, but that won't tell you sort of the day by day. So I think we rely a lot on self-report, which is not perfect, obviously. Yeah.
On the question of Prazosin, we do use that a fair amount in VA here for population, PTSD, and substance use. And do you have sort of a goal dose that you're talking about, or the studies that you showed that didn't show a difference? Is that like a fixed dose, or that's always our argument to the clinicians?
Yeah.
How far are we going to push it? How long are we going to wait for
it
to work?
So our dose was fixed. It was 16, so it was pretty high. But we did allow people, if they couldn't tolerate it, to stay, as you're titrating them up, if you had to stop. I don't remember what our average dose was, but it was pretty high. Somebody said maybe our dose was too high. I don't know. I think it's hard to know unless you really do a dose of, flexible curve. Now, I'm not sure if anybody knows in here, the co-op study that's just about to come out, that was large numbers. It wasn't in comorbidity, but it was in PTSD, and I'm not sure what dose they used, but that might be a place to look at, find some of those answers. Yeah, Matt. Yeah.
So I'm interested in hearing more about the logic with regard to the laboratory-based treatment and trying to use markers of reactivity, et cetera. I guess the question I have is, so nothing that you've shown really is gangbusters,
right?
And then you showed some evidence, I think, I went by pretty quickly, but that Prazosin, has an impact in the laboratory. And so I guess what I'm wondering is, do you see this, like really when you walk through the logic of this, of trying to use this as sort of a prelude to a greater investment, is it just a thresholding thing where you say, well, if it doesn't work at all on this, then we have no hope? Or is there some sense that maybe there's an issue of scale, that you're looking for things that are better than the current treatments for decreasing stress responsiveness before you would invest in a large-scale study? Do you get my
Yes,
question?
I totally get your question.
How does it work to sort of presage a larger investment?
Yeah, I think you're right. Some of the Prazosin laboratory studies were positive, which I guess you could say you should do that before you invest in a larger study. And I think that's what we were thinking, at least in our minds, that you try something in the laboratory, you see if it can attenuate stress reactivity, but then you don't know whether that will translate into working. You do, I think, stand the risk of missing something that could work because it doesn't do anything in a laboratory. But I think that, at least our thinking is you do it in the laboratory. If it has an effect, then it might be worth a clinical trial, whereas just doing a clinical trial might be, it takes so long. And
is there any sense that among the things that you think might do that there's some relationship between the degree of blunting of that response, or is it really just a binary, sort of threshold that it's got to be as good as Prazosin, or you're not going to get it in, you're not going to even try in the clinic? I guess I'm more wondering about that than whether you miss things. Clearly you're looking under the lamppost, so it might be a totally different mechanism that's never going to make it this way. But I think it's an interesting thought that you could try to use it at least just to advance this line of work. But right now it's just a binary that if it works, then you move ahead. If it doesn't work.
Right. Yeah.
Just following on Matt's question and what Marty was bringing up before about the limits of these laboratory studies, two things that stood out is you had a composite case that involved domestic violence, economy of the law. You also had this two-site study where you thought maybe people did better because they had better housing.
Right.
So where did things like 12-step programs, social, supporting work, that kind of thing, where does that fit into what you're getting
Right.
at?
Well, I mean, we haven't really, done research studies looking at least I haven't. I know people have looked at supportive employment, but I think that's one of the limitations, I hate to say it, of what we do, is that you're looking at things that may make some difference in the lab, but if you've got something that's so overwhelming a medication effect, like going to jail, risk of going to jail, place to live, being assaulted on the streets. I mean, these things could overwhelm anything. So that's one of the problems with doing. But not only does your medication and research overwhelm it, maybe your treatments are overwhelmed too. So you're right. You need this sort of more comprehensive treatment. I think at the VA we actually do it better than a lot of places because we have these ancillary. We have vocational rehab, and we have homeless programs and veterans justice outreach. For those of you who are at the VA, know what I'm talking about. And that may make a difference, but it's really hard to study that in a research study. But it's a really good point. Yeah.
Just another complication.
Yes. Yes. Yes.
So we have a contract with the VA here to do the pension compensation evaluation. So the most common diagnosis that's claimed is PTSD. So the question is it malingering or is it actual PTSD? And one of our junior faculty members and I just put together a paper which is submitted on false PTSD, and what we point out is it's not just malingering PTSD. And one of the faculty members in the VA told us that a patient came to him and said, "I'm going for these pension and compensation evaluations. Tell me what I need to say."
Right.
In order to, I served my time.
Right.
I deserve something.
Right.
And I wanted to say the right things. I mean, all of a sudden they're going to tell me I don't have a pension, and I fought in the war,
right.
kind of thing. But that there's also what we call in the article factitious PTSD. It's not just malingering for secondary gain, but it's also the identity of being a vet with PTSD,
right.
and going to these groups, and it just becomes part of who you are.
Right.
And so, medications,
right.
Right. Help.
Right.
That particular dynamic.
Right.
And a lot of these studies are self-report.
Right.
People say they
yes.
have it,
yep.
and it's really, really hard to
right.
separate out.
Right. Well, just to give you another term, when we were residents, we used to call it the upwardly mobile diagnosis because we'd much rather have PTSD than, say, schizophrenia. Who wants to have schizophrenia? But PTSD had this sense, especially at the VA. So, yes, you're totally right. Yeah.
Actually, one of the best illustrations, I think, of that phenomenon is the difference between the early U.S. combat veteran PTSD studies in which comorbid drug abuse was almost the order of the day, and the Israeli studies of PTSD, which included whether they were had been in the military as part of their, tour of duty, so to speak. It was much more of a civilian population, and the results were strikingly different, were actually much better because of the lack of comorbidity, and that people tended to have more pure PTSD. My question that I wanted to ask about is, I would think one of the things people agree about is that exposure therapy is good for PTSD. And you have to assume that a fundamental process is learning and relearning that's going on during exposure therapy. So you'd want to think about, if you're using medication with exposure therapy, how that medication would affect learning. The literature suggests benzodiazepines generally have been frowned upon because maybe they would interfere with new learning. You'd think topiramate, from that perspective, might have problems.
Right.
You'd think alcohol,
right.
to the extent it interferes with learning, would be a bad thing.
Right.
But most interesting, I think, is when you get to the norepinephrine system. People have used the noradrenergic blocking agents acutely, immediately after a traumatic event, to try and block consolidation of memory so that you don't get PTSD started in the first place.
Right.
You would think that norepinephrine blocking agents would have the potential during exposure therapy of blocking learning. And in fact, would you want to be enhancing norepinephrine?
Right.
I would think, from a sort of semi-laboratory, semi-clinical trial, and what I'm thinking is that you probably couldn't do this just at one session, but over a period of sessions, you'd really want to look at what enhances learning.
Mm-hmm. Well, that's a really good point that you bring up, and there's been some interest in using things like D-cycloserine in addition to psychotherapy to enhance, like glutamatergic agents to enhance learning. I think there was a meta-analysis that looked at that. I don't know the results of that, but that's a really good point that I think people have been interested in how to enhance psychotherapy or enhance like prolonged exposure using some kind of a medication that would enhance learning. So. Yes.
So I'm wondering because I know that there's animal model data that suggests that that you might want to do exactly the opposite, right? That during exposure and response prevention, that you might want to do the exposure and then use a beta blocker or something acutely, right? Which then prevents the reconsolidation of memory because it's not just apparently at the initial event; it's every time. And so it would be, I think, a really interesting idea to ask both questions, whether or not, enhanced learning versus an acute dose of beta blocker or something else in a laboratory setting altered sort of stress response in the future in doing this. Is there, I mean, I know that there was a lot of interest in this when the articles from NYU came out initially about this kind of paradigm for memory reconsolidation. Has anyone been doing that in a laboratory-based setting around?
We just reviewed an article where someone had done this. They had done a preclinical study and a clinical study looking at reconsolidation of in smoking, I think it was. I can't remember who did that study, though. It's because I read it a couple weeks back. I don't know. So, yeah, I think there are some people that are looking at that. And craving in the laboratory, you know what I mean? Not in comorbidity, just in terms of substance use disorders. Yeah. Yeah.
So, thinking about targets for intervention in addiction and in PTSD, and I have in schizophrenia now a problem with cannabis use that we're trying to think about formulating an intervention and being asked by NIMH to specify a mechanistic target by which our interventions work. We are increasingly looking at prefrontal cortex function and thinking about the role of cognitive control and impairments in cognitive control as being a factor in mediating some of the mechanisms that may maintain addiction, like delay discounting. And I think about Warren Bickel's work and using a working memory training to try to fortify prefrontal function. Other work showing that in fMRI of delay discounting, deficient prefrontal cortex plays a role in discounting delayed rewards. And I'm just struck that in all of the space that you discussed, including some of the pharmacological mechanistic targets, that circuitry doesn't actually figure prominently. And I'm kind of new to the area, so wondering if I'm being led astray by some of this work, or if you think that
no, I think you're,
there's also evidence that there is this deficient recruitment of prefrontal cortex and cognitive control in PTSD. So you may get a double hit.
Right. No, I think that's really interesting, and I think that there is definitely, I mean, if you think about when we did some of these early studies, people were interested in neurotransmitters, and I think circuitry is becoming much more, I think you're right on target in looking at that.
Are you thinking at all about cognitive training as an approach, or?
I mean, I haven't, but it's something to... Yeah. No. I think it's a yeah.
Great. Thank you so much.
Thank you.